Good day. It's Steve Anderson, and I'm here with our mentor and good friend, Dr. Arun Garg. Dr. Garg, as everybody knows, is dentistry's implant expert. Having spent an entire career in education, he founded implant seminars. And to my knowledge, there isn't anybody who is training more dentists today on how to do implants than Dr. Garg. With all of the seminars that he does around the country, as well as his live hands-on clinics that he does in the Dominican Republic, and now I understand in Arizona, probably placing or responsible for supervising the placement of more implants in the world than perhaps anybody else currently. So he covers a lot of ground. He's also the founder of the International Dental Implant Association, which is an organization of implant dentists, all of which have gone through his training and continue to refine their skills. So, Dr. Garg, thanks for taking a few minutes with us today.
Thank
I
you.
was looking forward to this conversation and wanted to divide our conversation into two parts. One, for those that are doing implants currently, what is what you would consider to be state-of-the-art in terms of technology, technique, and how implants are being done today? And then later on, I'd like to talk about suggestions and recommendations you would have for anybody who is not doing implants and what they might think about for the future of their practice. So with that, let's start out with the current state of implants and what you would consider to be state of the art. If I were a patient looking for an implant dentist, what would I look for? And if you were coaching a patient, telling them what should they look for, what would you consider as state of the art and what they should be able to expect in the marketplace today?
You know, so you're asking about state of the art, not just the standard of care, not just the basics, because I guess we're reaching out to cutting edge dentists to be the top level guys. So if we're keeping this TED Talk style and keeping it short, even then I'd like to focus on three things real quick. Number one, computer guides. And you know, in dentistry, nothing's been done with guides. A crown prep is just done freehand with a handpiece, albeit with principles that were learned in dental school, but not with a guide. A filling, not with a guide. An access prep for root canal, not with a guide. But now we have the opportunity to do things the way engineers did and architects did in the past, because they had guides. And so now there's opportunities to do implant surgery with a guide. There's opportunities. Orthodontic surgery now is done with computer guides. Okay, in the past it was freehand. And so computer guide is, and I'll tell you, for a guy that's been doing this for decades, I've been doing this for 30 years, implants, and we didn't have guides. And is the tough cases, I use computer guides routinely. And I started using computer guides 16 years ago when they're exorbitantly expensive. And when I left the university, went into private practice, my office manager, who worked for another dentist before and then came to our office, she looked at the bills for it and she was shocked. But I insisted. I felt that strong that for tough cases, and now as they become more and more prevalent, the cost comes way down. And so now it's not even exorbitant cost. Now it's state of the art, almost where it should almost be routine, as the cost is reasonable. And the tough part with guides was, how do I read the CT scan? How do I design the case?
Right.
But now what's happening, like with Invisalign, you don't design the case, you send it to them. You don't read the software, they do it. I'm working with this company actually in Texas, and they have radiology technicians that have been designing guides for 8 years. They design 10 a day. They design it. They read the CT scan. And then you get this thing for nominal cost. So guides is number two. In the past, the abutments, it's a 4-0 implant. It was a 4-0 abutment, but the cross section of the tooth doesn't look like a circle. I would say custom-made abutments. Custom-made abutments, so the emergence profile of the abutment coming off the implant has the same cross section as that natural tooth there would. And with that same emergence profile, better aesthetics, better hygiene maintenance, better is to maintain the soft tissues there, and now there's so many different companies that provide that. is custom abutments and a reasonable cost again is and the third thing, the most important thing is bone grafting, because what happens is if you're just not doing the bone grafting, is it limits you in terms of where you can place the implant, the size of the implant you can place. So feeling comfortable with bone grafting is, so those three things is computer guides, custom abutments, and bone grafts.
Let me ask a couple of follow-up questions. What's the cost difference between a standard abutment and a custom abutment?
5 years ago, the answer would have been stock abutment is $100 and custom abutment was $450. It was a big difference. Today, stock abutment has gone up to $125. Custom abutment's come down to $150.
So not much difference.
Yes. Okay. Yeah.
Bone grafting in terms of education, if you're taking somebody from scratch, you do this all the time, and getting them to the point where they could do bone grafting. I'm sure there's some cases more complicated than others, but what kind of an investment does that take to really get up to speed on that?
Well, there's a lot of different types of bone grafts, and it just depends on what level someone wants to get to. The easiest would be socket preservation. And is if you're asking from an investment point of view, I do a 3-day live patient program down in Dominican Republic. You come down for 3 days, you extract teeth, is you do socket preservations, you do PRP, is all on patients for $2,500 tuition, online patient for 3 full days. So that's the investment. And there's no chance if you do that for 3 days under supervision, live patient after live patient after live patient, you're not going to come back and do it.
So since you mentioned it, you are one of the original developers of PRP. Give us the short history of that and why it is so important.
Is myself and is Robert Marks, the two of us at the University of Miami. We were just trying to make things sticky. And so we were doing large bone grafts. We're trying to make them sticky. So we thought, okay, if we spin the blood, get the platelets, like get a test tube that's 10 milliliters, and take the middle 1 milliliters and get concentrated platelets and make the bone graft sticky. And we found is the bone matured twice as fast, it was twice as dense, and the soft tissue healed better. So we kind of stumbled on discovery. We're trying to make things sticky, and we made it sticky and growing faster bone and growing better soft tissue. And now it's taken off. We never patented anything, but now it's $40 billion a year industry. Oral surgery, orthopedics, they use it now for fillers, joints for athletes. It's everywhere.
And not that too difficult to do it in your office.
No, it's a centrifuge, $800 centrifuge and 50-cent test tubes.
There you go.
And a little half-day training or 1-day training program for the team members to learn how to draw blood and spin it.
Easy enough. You make it sound easy.
It is. It is. We do the program for 30 assistants at a time, and we do that program about 30 times a year. We train 900 dental assistants a year is on how to do it for their doctors. And we train several hundred doctors as well, of course.
Right.
Yeah.
All right. So that gives us an update on at least technology where we are today. Maybe you can just give us a context of what is the market for dental implants today, just in the United States. What's the opportunity? And then I want to talk about how you get started if you're not doing implants today. Well,
if you look at the number of folks that are missing a single tooth, there's over 50 million Americans missing a single tooth. And if there's 250 million Americans, 1 out of 5 is missing a single tooth. So that's 50 million implants just waiting to be put in. Slam dunk single onesie kind of cases. There's another 50 million that are missing 2, 3, 4 teeth. So even if there's 2, that's about another 100 million missing teeth. And if there's 3, it's 150 million. So between those two categories, that's 200 million missing teeth. And then there's about another 20 million, 15 million, 20 million that are missing all their teeth. And when they're missing all the teeth, that doesn't mean they're going to get 32 implants. Well, let's say 4 per arch, 8. So that's another 100 million. So there's about 300 million implants that need to be put in this country right now. Last year, 10 million went in. 10 million went in is, and 300 million need to be put in. That's 30 years for us to catch up. And even if you think about the doctors, okay, that are listening to this, if you think about the number of extractions they did per year, and compare to the number of implants they place per year, I mean, it should be 1 for 1.
Right.
But it's not even close. If I had to guess, the average is dentist out there is extracting 200 teeth per year, but implanting maybe 10, maybe 20, maybe 50. Okay, so that discrepancy keeps on getting bigger as it doesn't get smaller.
Average number of extractions that you would, just in general, say where you do an extraction and it would be an opportunity to immediately place an implant, what percentage of the time?
I tell folks when it depends on where they're at. So if they're beginners, I tell them don't do that.
Right.
Okay, because they don't know how much crustal bone loss you're going to have. And so you put the implant here, you get crustal bone loss, you got threads exposed. Okay, you're not so good at suturing. Some of the graft material comes out, you get threads exposed. Okay, so I tell them when they start, just do socket preservation.
Got it.
If 20% of the graft material comes out on socket preservation, pat yourself on the back. Well, pat myself on the back. Yes, 80% stayed in. And you're 80% better off than you were back before you started socket preserving. Okay.
All right.
But if I do an immediate implant, 20% comes out, you don't get to pat yourself on the back.
All right. So if I'm not doing any implants today and I'm thinking about the future of my practice and thinking about adding implants, getting that education, which I highly recommend, even though I'm not a clinician from a business side, it only makes sense. Would it be safe to say that step number one, even if you don't know how to do an implant, is you ought to start doing socket preservation?
Absolutely. Absolutely. And that is not just if they're going to get an implant there, because you maintain a big fat ridge. What if they're going to get a bridge there? Better to have a big fat ridge under the pontic. What if they get a partial denture? Better a big fat ridge under the partial. They're full denture. Better a big fat ridge under a full denture. Okay. In every single scenario, socket preservation. And is when we go through it and we train folks, they get 95% case acceptance on socket preservations. So you take a 20-minute extraction, that might be 150. And you add in a 5-minute socket preservation, that might be 300. So you tripled your hourly production, but more importantly, did a valuable service for the patient, but valuable for the office, triplet, and with a 95% case acceptance.
It's a no-brainer.
Yes, exactly.
Okay, so that would be safe to say that would be, if you're not doing anything else,
you've got to do that.
That ought to be a first step.
Yes. Yes.
What's next?
Is after that, then implants.
Okay.
Okay, then implants in there.
So what do I do if I'm not doing any implant dentistry at all? Give me the easy way to get, I know there's no easy way, but if you're going to map out the path for me to get started in the right way, where would I start?
Years ago is when I started teaching at the university as residents. And then I said, okay, let me start continuing education. I set it up like a residency program. I set it up a full year, 1 weekend per month. And I skipped a month because I needed a break. So I made it the 11-month implant training program. Okay, 1 weekend per month for 11 months. I had the guest speakers come in. I had, P.I. Brandemark come in for one of those days. Richard Lazaro, the guy who founded 3i Implants, come in for a day. The guy who founded Camlog Implants, Axel Kirsch, come in for a day, and so on. And that program we've kept. And so we've still got that 11-month program. And for the guy who wants to make implants like his specialty, that would be the way to start. But when I saw over the years, a lot of folks said, you know what, I don't want to make a specialty. I want to make it a part of my general dental practice. The way I do endo, the way I do extractions, not make this. So we do a 4-session is implant continuum that I do all the lectures myself. And so everything contiguous, no differences of opinion, step by step by step. And I offer that in 15 major cities around the country. So that would be the entry way.
Got it.
Every now and then I find folks that said, well, I've taken either in dental school or in my GPR residency, or even for some other course, I've taken a lot of didactic material. And I don't want the 11-month. I don't even want the 4-month. I would just like a 2-day program. So I got a 2-day program, called Implants Unlimited. Every now and then I get folks that say, I don't even want the 2-day program. I've had so much didactic and I need the hands-on. I like to go straight to hands-on. So I call it Implant Boot Camp. We go straight to Dominican Republic. I still give an hour per morning of lecture still to get everybody on the same page. So that would be the 4 ways to enter. The 5th way that we're in the process of putting together is 50 hours online. Okay, so there's 5 ways to enter. The most common is the 4-session program, the implant continuum. But the others, 11 session, 1 session, directly to live patient, or 50 hours online.
Yeah.
5 entry points. And so it depends on the time, depends on the finances. And then after that, if they wanted to, which I would recommend, live patient. And for live patient, we've got Santo Domingo. We now actually have Santiago, another facility there. And now, as you said, we also have Phoenix. So they could choose, they want to travel international, don't want to travel international, although international Dominican Republic is an hour and 45-minute flight from Miami. So it's like a domestic flight. But yeah, but 3 different options is for them.
Why don't dentists do implants? If they don't do them, what are the biggest reasons they don't do them?
Well, I think as a lot of the top performers actually do, but the ones that haven't, it's sort of like all of us. It's just inertia, is they may not have gotten around to it. Is they go, well, I'm gonna start, using that Bowflex I bought. I'm gonna it's there. Okay.
Right.
So I'm guilty of the same thing. They just didn't get around to it. That's a lot of it. A lot of it is they didn't realize that they can actually learn it. Okay. Is that this is not something that you're born with, that you're trained on it. And this didn't understand that or have the confidence that, yeah, okay, I didn't realize I could be trained on this. I didn't realize I don't have to do the 11-month and become a specialist. It can be a part of my practice the way I can do endodontics without being an endodontist, the way I can do extraction without being an oral maxillofacial surgeon, the way we can do deep cleanings in our practice without being a periodontist. Okay, that yes, I can do a substantial amount of them. Okay, is in their mind, they might either believed or erroneously been told in dental school that no, you've got to be all in or not in. It's not a part of general dentistry, and it very much is.
Big market for it. And from a patient practice standpoint, we've always held that most patients, if they have the confidence in your competence, they would prefer to stay with you in your office, in your chair, than have to go somewhere else and establish a different relationship with somebody they don't know. If they have the confidence in you, they prefer to stay. Would you agree with that?
I see that all the time. I talk about my classes and I ask, because I travel, every weekend, and I meet 50 doctors each weekend, and I ask them, and they say, yeah, half is the ones that before they took the course are referring out. They go, half don't go. They say, I'm going to send you Dr. Smith down the street. You're going to love him. He's great. We refer to him all the time. I send my mother to him. They go, oh, you mean I have to go somewhere else?
Don't do it.
I'm okay then, doc. I'm fine just the way I am.
Or they say yes and they don't get around to it.
Yes. Okay. Yes.
It's just one more step they have to take. So make it, as they say in the technology world, frictionless.
Yes. Yes. Frictionless. Absolutely.
Perfect. Thank you for the update. Information on your courses can be found.
Oh, at implantseminars.com.
Easy enough.
Yes. Implantseminars.com.
And I want to personally thank you for your great mentorship in the Crown Council and your participation in Smiles for Life. We've done some great good together in the Dominican Republic that will continue moving forward to benefit patients that otherwise would never have any care in that country. And you have a specific interest there because of all the education you do there. So we appreciate your engagement, your participation, and your commitment to all of that. Thanks for your wisdom, as always.
Excellent. Thank you.
And look forward to talking to you again soon.
Okay.